Here we have, how does poverty and stigma contribute to the exacerbation of mental illness, and what role do providers play in this dynamic? Poverty worsens mental illness symptoms, and mental illness worsens poverty through gaps in knowledge of basic needs and capabilities. Stigma hinders individuals from seeking treatment, creates detrimental side effects like poorer self esteem, empowerment, self efficacy, and lower social support. Stigma lives within doctors treating mental illness, which risks patients' mental health. And finally, insurance companies play a role in mental illness stigma through lack of access to mental health care, and those suffering from poverty do not receive adequate care. All these issues are interwoven and affects our society. Mental illness, stigma, and poverty contributes to the exacerbation of negative mental health characteristics such as lower self-esteem, self-efficacy, stress, and having basic needs and capabilities resolved. Mental health physicians and activists have been trying to advocate that mental illness is just as severe as any physical ailment, but this is paired with discrimination from doctors and insurers within the same sector of the medical industry. This is detrimental to the entire population of those suffering with mental health and every step of their recovery process. Literature review. So Livingston and Boyd conducted a meta-analysis on 127 studies, and descriptive analyses were used to examine the proportion of studies that found a statistically significant association between internalized stigma and another variable. The authors found that internalized stigma was moderately correlated with symptom severity, treatment adherence, and these results continued with hopelessness, poor self-esteem, empowerment, self-efficacy, decreased quality of life, and lower social support or integration. Looking at the picture on the right, these things are some examples of what in our society may cause internalized stigma, but it does not stop here. The medical industry, including doctors and insurance companies, play a major role in these perpetuated stereotypes. Mental illness and insurance providers. So Kahn brings up the realities of stigma carrying over into the insurance industry. Insurance companies didn't want to cover mental health at all. A large part was because of its susceptibility to abuse within the insurance sector. And once insurers finally did add mental health coverage, they created limits on its use, even though no similar limits were made for other kinds of illnesses. Once it finally did cover mental health, it exploded, and it resulted in the use of managed care. This created a difficult environment for receiving quality care, low reimbursement, and exacerbated stigma in the field. Since then, advocates have sought stricter enforcement of regulations like promising an adequate network of providers and lower out-of-pocket spending for the low-income population. Advocates today use brain scans and diagnostic techniques to clarify how relevant mental illness is as a physiological and pathological phenomenon. Doctors and mental health professionals have been trying to make the point that those suffering from depression, bipolar, and schizophrenia, just to name a few, are suffering from a disease that is as real as cancer, diabetes, or a heart attack. Mental illness, stigma, and physicians. Mental health providers have the power to negatively impact care through stigma. The combination of prejudice and social power leads to discrimination and marginalization. Unfortunately, providers have a prevalence of these beliefs within the general population. Cats and other authors conducted a study within the VA healthcare system with 77 mental health providers completing a self-report measure of stigma towards those with mental health diagnoses. What they found was that male mental health providers hold a significantly more stigmatizing view towards those with schizophrenia and post-traumatic stress disorder. Mental illness and poverty. Poverty is a distressing and damaging variable added to those suffering with mental illness that thwarts recovery and stunts individuals' ability to live the lives they want for themselves. This is not an inevitable outcome for those suffering with mental illness, but it is one that persists 40 to 50 years after the deinstitutionalization, despite interventions through community support, employment, and housing. Sylvester and other authors find that addressing poverty requires a team effort through community psychologists and practitioners from other fields to create progress through research. The authors point out that the individuation of those with mental illness may contribute to poverty because it does not reach outside the scope of the individual to issues like basic needs and capabilities, which enable people to gain meaningful roles. Just like Livingston and Boyd mentioned in the previous slide, mental illness may cause low self-efficacy, which in turn leads to the lack of access to basic capabilities. Does financial stability affect mental illness or poverty? So several studies indicate the relevance of poverty in psychological disorders. However, causal effects on poverty alleviating mental disorders are not understood. Wolberg, 2023, sought to understand this relation through a meta-analysis of 17 studies with 26,794 participants in Sub-Saharan Africa, Latin America, and South Asia. The authors created randomized controlled trials evaluating the effects cash transfers would have on participants with depression, anxiety, and stress. Their findings suggested that cash transfers played a small role in decreasing depression and anxiety symptoms, but continued financial support was necessary for long-term effects. So the study aims to point to the need for unconditional long-term financial support to address the poverty mental health cycle for those living in poverty, comparable to Sylvester and other authors' suggestions for providing long-term care with basic needs and capabilities. Data collection. So for this research, I chose to include poverty, stigma, and provider experience in in-depth interviews with 3 participants. This interpretive approach allows for a more in-depth understanding of each participant's experience with poverty, stigma, and providers when navigating mental illness. Each question asked to the participant will allow for exploratory conversation while adjusting the questions as new insights and findings evolve. Results were based on personal opinions and experiences instead of numerical data. This will permit a wide range of responses, but the information that it provides allows complex individual interpretation. Furthermore, questions were designed without the words stigma or poverty to avoid steering or prompting the respondent to ask in a specific way. This would allow for more reliable results. Data was collected via video calls on Zoom and recorded to later transcribe via Microsoft Word. 3 persons were chosen of close relation to the researcher that have all experienced mental illness personally and with surrounding relationships. Each person was informed verbally that the interview was for a research paper regarding mental illness in a class at California Baptist University. So the interview questions included here is referring to the literature review, right? So they found conflicting views on provider stigma within the sector of providers for mental health, where on one side, providers are advocating for depression, bipolar disorder, and schizophrenia to be considered as real cancer, while on the other side, displaying stigma of disorders like post-traumatic stress disorder and schizophrenia by male providers, right? And because of these conflicting views, questions regarding provider experiences were introduced using the following questions. How has your experience with mental illness been within the medical industry? Example, providers or insurance, positive or negative. The remaining questions were meant to allow participants to include stigma experience with providers if they felt it was pertinent to the conversation. Livingston and Boyd, 2010, found that mental illness stigma exacerbated mental health symptoms, while Kahn, 2015, found that stigma continues into the insurance companies concerning coverage. And in order to learn more about the perspective of a possibly stigmatized person navigating the insurance industry and life, the following questions were asked. What is your understanding of mental illness? Have you ever been diagnosed with a mental illness? If yes, how did you feel when you were diagnosed and why? How is or was your experience with mental illness affected your relationship with others? And was there ever a time that your mental health was not covered by insurance? The final question asked was regarding mental illness and poverty. Have you ever experienced food or housing insecurity? And if so, how did that affect your mental health? This was to look closer at what Sylvester and other authors mentions. Addressing poverty requires a team effort through community psychologists and practitioners from other fields to create progress through research. Essentially, recommending more than the individuation of treatment for those with mental illness because it contributes to poverty. This question allows further depth into how poverty exacerbates mental illness and what role providers play in helping or hindering that process. So finally, some of the limitations here was that due to time constraints, the method was considered because there was no possibility for IRB approval for ethics. The participants' previous experiences in and with mental health were previously known by the researcher, bringing the possibility of bias because these experiences may not be that of the broader population. Typically in sociological research, a sample allows for the subjects to represent the larger population. So instead, 3 available participants were chosen based on their known connection to mental health from previous conversations prior to research. Finally, the small sample size, especially specifically chosen due to their connection with mental health, does not allow for reliable generalizability of the sample. So results and analysis. So mental illness stigma personally and within the medical industry. So the answer to the first question, what is your understanding of mental illness? Displayed acknowledgement of stigma in previous generations by the first participant, and all 3 did not seem to hold a stigmatized belief of the definition of mental illness at all. But this changes for the first respondent later in the interviews. So the first response to the question is, do I have friends that have mental illness? Yeah. I think it's something that we're just now becoming publicly aware of, and the public perception on it is growing more accepting compared to previous generations. For my parents and my parents before them dealt with things like anxiety, they'd just suck it up and then kill yourself or drink yourself to death and beat your wife or something like that. It helped me not treat mental illness this way and take mental health issues seriously. So here we see some generational stigma And then I mean, I know that at some point, as when I was a kid, mental illness is equivalent to physical pain. It is a real diagnosis and it affects my entire family in a significant way. A mental handicap or inability to handle normal situations due to whatever is going on. And finally, chemical imbalance in your brain. Intense amount of trauma or drug abuse or genetics. Pick your flavor. So, how did you feel when you were diagnosed and why? So, all three participants were at some point diagnosed with anxiety, depression, panic attacks, ADHD, and drug addiction. One felt stigmatized because of the stigma that was experienced from the earlier question that something was wrong with the respondent. This is like the point made by Livingston and Boyd, where internalized stigma causes individuals to endorse stereotypes, anticipate social rejection, and believe that their place in society holds no value. However, the other two respondents felt more relieved when there was an explanation for their behavior and feelings when dealing with life, possibly showing that what Khan said and mentioned, where advocates have doctors and mental health professionals have tried to stifle the stigmatization in mental health, maybe showing some improvement. Mental illness stigma and roles that providers play. So each participant's response to how or is or was your experience with mental illness affected your relationship with others shows the stigma placed within society that does not have a complete understanding about what mental illness may look like. One person, it affected their relationships by making others feel attacked, while another person suffers with executive dysfunction but is seen as forgetful or inconsiderate to others. The third seems as if they have come to an understanding of how mental illness affects them and others and has grown to be more tolerant. Most of the participants have had insurance coverage for their mental illness, but one struggled to keep it once employed. You can pause and read the responses verbatim. Providers in poverty. So overall, the respondents reported a generally positive experience with providers and insurance, with a few difficulties along the way, mostly with contacting providers, but once being seen, the experience was generally positive. When participants spoke about having any kind of financial insecurity, there was heightened mental health symptoms like anxiety and depression, much like discussed by Wahlberg, 20, where small cash transfer played a role in decreasing depression and anxiety symptoms. Pause to read the answers verbatim to these questions. So concluding remarks. So the interviews conducted show some of the effects of stigma, both internalized and within society, with mental illness. Poverty heightens mental illness symptoms due to the fear of not having basic needs covered to live. The literature shows the detrimental effects of stigmatizing an already marginalized group. The study had limitations in time, bias, and generalizability. However, the respondent stories entail lessons for those continuing to stigmatize very real diseases. Like this picture shows here on the right, every part within this study and the endless cycle caused in this multifaceted issue. First, we have internalized stigma, then mental distress, an increased likelihood of depression and anxiety and other disorders, then reduced help seeking, treatment, then poor treatment, then stigma and social exclusion, the limited resources, and the cycle continues. Advocates may have made a dent in this issue, with more and more seeing the value in destigmatizing mental health, but more work is to be done. Here's a list of the references used within the presentation.